Neurology quiz number 41. What are the different modes of treatment for trigeminal neuralgia? These are medical treatment. First-line medications are usually carbamazepine, 200 to 1200 milligrams per day, or oxcarbazepine, 300 to 1800 milligrams per day. Carbamazepine has the best evidence as long-term treatment and is reported to be effective in 70% of patients, though tolerance can occur. Side effects like drowsiness, cognitive symptoms, dizziness, ataxia, skin rashes, hyponatremia can limit its use. Oxcarbazepine is better tolerated but has a higher incidence of hyponatremia. Alternatives with weaker evidence include lamotrigine, gabapentin, and botulinum toxin type A. Other medications used are baclofen, topiramate, sodium valproate, levetiracetam, and phenytoin. Patients may need multiple medications for adequate pain control. Medications work better in the paroxysmal form of trigeminal neuralgia with shorter attacks as compared to patients with concomitant persistent facial pain and with longer attacks. Rescue treatment. Patients may present with acute exacerbation that is refractory to medications. Pain can be severe enough to interfere with eating and drinking and may require inpatient treatment. Options for such patients include IV fosphenytoin or IV lidocaine, which requires cardiac monitoring. Acute pain relief can also be achieved with nerve blocks of the most affected trigeminal nerve branches. Surgical treatment. This is indicated if an adequate trial of medications does not provide relief or causes intolerable side effects. Microvascular decompression is considered the treatment of choice if MRA shows neurovascular compression by an abnormal vascular loop. This usually originates from the superior cerebellar artery or the anterior inferior cerebellar artery. In patients without neurovascular compression, a neuroablative procedure is typically considered. Microvascular decompression involves a craniotomy and posterior fossa exploration. Vascular loop is relocated away from the nerve and a piece of synthetic material is used to create a barrier between the vessel and the nerve. Compared with other treatments, MVD is reported to have the highest success with 70 to 90% of patients pain-free at 1 to 2 years post-operatively and 65% of patients pain-free after 10 years. Complications include ipsilateral hearing loss, facial palsy, facial numbness, CSF leak, aseptic meningitis. This figure shows MVD surgery and shows the site of craniotomy, the abnormal vascular loop, and a Teflon sponge placed between the vascular loop and the trigeminal nerve. Neuroablative procedures include stereotaxic radiosurgery, which involves aiming a carefully targeted external beam of radiation to a part of the trigeminal nerve root to induce focal axonal degeneration using a gamma knife. 85% obtain pain relief, which may take 2 weeks to 2 months, and by 5 years, 35 to 55% are pain-free. Sensory loss is a common complication. Percutaneous lesioning of the trigeminal nerve. This is performed under fluoroscopy and involves passing a long cannula into the cheek and through the foramen ovale and lesioning the trigeminal branches or ganglion. Lesioning can be achieved by radiofrequency thermocoagulation, chemical destruction with glycerol, or mechanical destruction by balloon compression. Initial pain relief rates are high, more than 90%, but decrease to 50 to 70% pain-free at 5 years. Sensory loss is common. Partial sensory rhizotomy involves surgical section of the sensory root of the trigeminal nerve. This is a picture of stereotaxic radiosurgery, targeted external beam of radiation focused on the trigeminal nerve to induce focal degeneration using a gamma knife. The red circle in the MRI shows the site of radiation dose delivered to the trigeminal nerve. This is a figure showing percutaneous lesioning of the trigeminal nerve. This is performed under fluoroscopy and involves passing a long cannula into the cheek and through the foramen ovale and lesioning the trigeminal branches or ganglion. Lesioning can be achieved by radiofrequency thermocoagulation, chemical destruction with glycerol, or by mechanical destruction with balloon compression. And finally, partial sensory rhizotomy, which involves surgical section of the sensory root of the trigeminal nerve.